Hey everyone, Dr. B here of Ask the Dentist. I'm very excited today um, to speak to Cody, Dr. Kriegel. He's in Iowa, right? Right.
From the Midwest.
That's
Yeah.
right, Midwest. But I'm
Yeah.
very excited because I met Cody a while ago, and we've been talking a lot, which has been great. For me, I was just pleasantly surprised. As you can imagine, I speak to a lot of dentists every day, one or two. And it was so refreshing to speak to Cody because he's fresh out of dental school. It was so refreshing to see how he kind of grasped this whole functional provider concept so easily and has been for so long. Because when I speak to a lot of dentists, a lot of elderly dentists, ones that have been out for 34 years, they just don't get it. So Cody's attained a membership and fellowship status. Fellowship status is a big deal in our postdoc training as dentists in the International Congress of Oral Implantologists. That's the ICOI. He's also a member of the American Dental Association in Iowa. And you were born and raised in Eastern Iowa, right? And you're practicing in your hometown, which I think is fabulous because, I think that's wonderful. I think that's a great story. You don't hear it too often, but I think it's great. I was just so impressed when I met Cody, and I think you'll be very impressed too, because we're going to talk about implants, and there's a lot to implants, and there is kind of a functional approach to implants as well, which kind of goes beyond just seeing a regular dentist or implantologist for that matter. And we're going to talk about titanium implants and maybe why you should be thinking about zirconia, which is something new in implantology, and what is the best implant option for you. So let's get into it. Thanks, Cody. Good to see you.
Yeah, it's awesome to be here. I'm excited.
So let's state the obvious, or let's talk about the obvious. What's an implant? How does it work? How is it placed?
Totally. So a dental implant is used to replace a missing tooth or a tooth that can't be saved for many reasons. It's a permanently implanted biomaterial. So we kind of liken it to, if you have a prosthetic knee or hip, everybody kind of understands those nowadays. And with that comes a couple of things. You have to kind of think about the mouth is an interesting area. It's got bone, it's got tissue, and it's got a microbiome that is incredibly diverse. And a lot about that as well.
And so it's not like putting titanium into your hip. It's different, is what you're saying, because the mouth is a different part of the body. It's very unique.
We have to kind of be really nuanced on what we're placing in there and why, and then what those materials, their systemic effects can have.
Right. When do you pull the trigger, so to speak, on extracting a tooth and putting the implant in?
In our office, and in a lot of offices, I think across the U.S. and the globe, I think what we need to do is make sure everybody's making an informed consent, an informed decision on what they think is best for themselves. For most patients, it kind of comes down to, gosh, if you have a really deep cavity that you're unable to restore long-term, get a good restoration on there, or if you have a really infected tooth that can't be saved in that way, shape, or form. Teeth are important, and sometimes we don't know what we have until they're gone. And so once a tooth is gone, we start to realize, oh shoot, I can't chew the foods I want to eat. Maybe I'm losing some facial structure, aesthetics, those type of things. And so every case is a little bit different, but you kind of have to know, hey, is the tooth able to be saved? Is it still going to be able to serve you the way it's supposed to? Or is it one where we might want to cut our losses? And
yeah, I'm always weighing the cost and the time commitment of the patient. And if there's any chance of for example, if a tooth needs restoration, obviously you're going to need a crown. It's a big cavity. The tooth has maybe died, which means there's an infection of the pulp, which means a lot of dentists would be looking at a root canal. But with the advent of the implant, there's a new kind of triage kind of course that we can take, and that is maybe we shouldn't do the root canal because the implant is a better long-term. Why not just jump to the next step, which will last longer, fewer complications? Root canals have a lot of complications. There's a lot of controversy now about root canals because you're disinfecting, not sterilizing. You're trying to sterilize something inside the body, but there's still some tissue in the lateral canals, accessory canals, and there's some concern that can cause systemic issues, inflammation, and there's validity to that.
Oh, absolutely.
And
I
that's
see patients like that every single day in
exactly
our clinic where, and again, I think we have to be careful with blanket statements, you know.
right.
There's a bio individuality that happens with every human being. Our systems are so complex and so different, and also the same in many ways. But you're right. And going back to your point with root canals as well, with the advent of CBCT and cone beam technology, we're able to
Mhm.
analyze
Right.
teeth at a much deeper, finer level. And we can kind of start to see that, hey, maybe some things that a root canal is a tough procedure,
Right.
and it's a lot to ask out of a procedure.
It's very technique sensitive, and there's some teeth that I just wouldn't, even in the best hands of an expert endodontist, someone that does root canals all day long, like a first molar with 5 canals and tortuous canals. I just think it's better to. I mean, I have this discussion with the patient. I say, listen, this tooth has a very poor prognosis. Maybe you'll get 5 or 10 years out of it. In the old days, I'm talking about when I was a young dentist. I mean, we tried everything to save the tooth. Keeping that tooth in place was imperative. Loss of tooth, alters facial structure, it causes the bite to collapse, and a host of other things as well. And loss of a lot of teeth, being edentulous or partially edentulous, does shorten your life. We have studies that can
Absolutely.
support that. Now, thank goodness, we have implants, essentially the artificial tooth, and we can
Mhm.
place an implant and not have to do all that heroic dentistry and cause the patient a lot of harm and systemic issues. Yeah, implants have been wonderful. I always tell a patient that if you could do the root canal, which is $1,000, $1,200, $1,300 insurance, if you have it, may pay
Mhm.
80% of it. The decision or the critical kind of calculation that has to be made is, why not just jump to that step first, spend money well, good money well, don't waste it on the root canal and the crown, inevitably, that has to go on top of the root canal.
Yeah.
And that's where I try and really help the patients. And that's why you're seeing so many implants, because you're seeing a lot of people with root canals that have failed. And I know the surgeon next to me who does implants, that is the bulk of his practice. Yeah.
No, true. And I think, I routinely, depending on when I get a patient that has some various systemic illnesses and things, I will routinely test that root canal, get a DNA report on that with the PCR test, and just see what's going on inside that tooth. Maybe it was related to something that they're going through, or at least burdening their system,
Right.
so it can't, give it soldiers to somewhere else. And so we, again, looking at CTs, you start to see, oh man, there's a lot of this, a tough procedure, and there's a lot of them out there that are kind of uh, becoming low grade chronic infection. And with that becomes
Right.
kind of a cytokine storm.
Let's talk about that. I know, again, it's related to root canals, but a lot of people have root canals and they're thinking maybe they're not healthy because of that, and they're going to want to go to an implant. So you mentioned the CBTC, the cone beam.
Yep.
I'd like you to talk a little bit more about that, why that's so important, and then also the DNA testing.
Yeah, so the cone beam is, I always tell patients it's kind of like a Star Wars machine. It spins around your head and it looks
Yeah.
like it's from another dimension, but and that gives us basically a three-dimensional snapshot of your jaws. That allows us to look at not only the top of the tooth, but all the root structure down inside the bone, and also evaluate where are your anatomical structures. We forget how intimately connected our mouth is to not only our brain and our brainstem, but the rest of the system.
Right.
So that cone beam allows us to really just get a really, really deep view of what's going on inside that tooth, and if there's an infection going on with it, and we can catch it, when you don't even feel it. And that's a pretty routine thing in our practice.
Right. Testing, DNA testing.
Yeah.
Yeah.
So typically I do that after I take a root canal out. But typically we'll take it out. We'll cut off the top of the tooth or the crown of the tooth, so that
Right.
we're only testing the roots. We're only testing something that wasn't
Good.
exposed directly in the mouth. We take the crown off and send in the roots, and then they basically do a PCR test, and they can give us just a kind of a snapshot of a risk factor based on how
Mhm.
virulent what bugs are in there, how virulent are they, and what's their load.
I wish more dentists did that, because that information, even though it's after the fact, is important, because it would help explain to the patient. It would be great because that patient's going to tell another patient, and
Mhm.
we'd get more knowledge, more baseline knowledge of, this interaction between what happens in the mouth, happens in the body, the oral systemic connection. But it also helps in regard to that individual patient. Let's say they have like rheumatoid arthritis. It would even though it's not going to go away necessarily just because you took out that tooth that was involved or contributing to that, but at least it gives them an idea, or that practitioner, the MD or whatever practitioner they're seeing in regards to treating that, some more information. I mean, information to work with, and I think that's wonderful. What kind of bugs do you see typically on the bad side? What are you seeing? I'm curious.
I've seen you can run a Lyme panel as
Right.
well. You can get Lyme, and Borrelia and different variations of Borrelia in there. I
Right.
see parasites.
This is stuff that's not readily apparent to the dentist or the patient. And again, it's in hindsight, but the more we know about this and the more data we collect when we take these teeth out and find this out, these are all anaerobic, these are anaerobic conditions. So a lot of these bugs are anaerobes, and anaerobes are in the mouth already, but not at the concentration that they are necessarily around a root canal tooth. So,
Sure.
and then of course you need bone for the implant placement, right? So a lot of these bacteria are causing necrosis and loss of bone. There are cases where you cannot place an implant. So let's talk about that. How long should someone wait if they have an infected tooth? I mean, waiting too long obviously is bad. The loss of bone is bad.
You don't want to wait at all if you can. And I understand there's always circumstances that are with every patient, whether it's a financial thing or a timing thing or whatever it may be. But I mean, the longer you wait, it's just the more of a risk you take of where, that infection could get bigger. It could, remove, I guess, for lack of a better term, resorb more bone structure in the area to make it where an implant isn't able to be placed the same day, or there's more cleanup. So your healing is going to be a lot slower.
It's a tough call. And of course, a lot of people, cost is a factor. So what does an implant cost?
So I think in a typical implant, again, it kind of ranges a little bit on where you're at. I'm in Iowa, so things are a little bit different here than they are probably in the heart of LA.
Right.
But I think typical of 4 to 6,000, I think, for the whole implant procedure. And sometimes that would include the removing the tooth as well.
And the bone graft if necessary.
Yep. Bone graft if necessary. And those are all things that, again, when you are able to read a cone beam and assess, and then sometimes you don't even know after that. It's kind of when you get into the site and you kind of get a feel for what the bone's like and how bad is the infection. Is it worse than it looked like it was? And then other procedures that might need to go along with that is what I'm saying.
In my day, we were told never to place an implant on someone who smokes a cigarette. There were a lot of other cautions given to us. That doesn't seem to be the case today. What is the success rate of implants, and what patients seem to have problems with implants? The loss of the implant, implantitis, which is bone loss and essentially a form of gum disease or breakdown of the supporting tissues around the implant. That's possible. How much of that do you see?
For sure. Yeah, so an implant success rate, some of those numbers are a little bit all over the map, but for the most part, I'm going to say 96 to 98% success rate.
Right.
As far as the peri-implantitis, so that kind of infection or inflammation of the tissues, hard and soft bone and gum tissue around an implant, those numbers are really all over the map. And I think some of it comes down to how they're classifying that. Somebody might say, well, if you can chew pizza on it and it works, then it's fine. And somebody might say, well, if it bleeds a little bit though, that's a sign of an inflammation, and it technically is.
But here's an argument that I make often, and that is the person who's placing the implant should be also doing the restoration. They should be doing it from start to finish.
Totally. I agree. I think what makes a good implantologist, makes a good dentist, is knowing what to do when things go awry. Going to your part, there's going to be a lot of reasons why an implant fails, and some of it is a systemic issue with a patient, and we just don't know. And everybody heals differently. Sometimes it's, like you said, the occlusion, the biting, how a patient's bite, that's very, very important. And it becomes when you have somebody placing the implant and somebody restoring it, and if they don't have a good intimate relationship like you probably had with your doc, then it becomes a pointing game with the patient stuck in the middle a little bit.
A lot of dentists can get like video training and all of a sudden they're placing implants, which is a frightening prospect. And I also think oral surgeons should be allowed to place the crown if they're putting the implant in. But there are these territorial political lines drawn in dentistry that if you're a specialist, you can't place a crown. I don't know if patients are aware of that. I think that needs to change. But talk about the training that you've had and why you think that's so important.
Yeah. And again, it comes back a little bit to having the right technology at first and foremost. I mean, we placed implants for a long time without some of the things that we have. And now we can get rid of some of our old mistakes or learn from them and utilize newer technologies to be a lot safer and cleaner with implant surgeries. And there's a lot of different pathways or training pathways out there now. Yes, you might have to fly into a couple of places and do some long weekends and some trainings, and then have for your first one in office. A lot of times the implant reps will come in and they'll make sure that you know how to use the parts and pieces appropriately and things like that.
What is the difference between a functional dentist and a conventional dentist when it comes to implant placement?
I'm a health-minded person. I like health. It's fascinating to me, and it's always been a part of who I am. And as I got out of dental school and I started to do some research for myself, and I think it always starts with being just open-minded. I think we can take that into anything, whether it's at the dinner table in this day and age with the craziness going on, or being open-minded and willing to learn more and more is always where things start. And since I love health, it was a natural marriage of what I loved and my career to put the two together. And we need to take that approach and understand all the interplay between our body and, for example, the microbiome.
Yeah, I think that whole functional approach is important, and I think it covers a broader area of health, so that there's that intersection with medical health. And unfortunately, there is this schism between dentistry and medicine. But a functional provider in the dental world, essentially, because their bubble's a little bit bigger, their coverage is bigger, I think the patient's getting a much better service, because there are a lot of things that the physician doesn't know that should know, that are being caused by dental disease. And if you're just seeing a drill and fill kind of dentist, that's really just has become a very small subspecialty of medicine, which the doctors aren't even aware of. I mean, I think most patients, and a lot of dentists, most dentists are still, when they think of an implant, they think of titanium. So is that something we should be considering? There's a new kid on the block, not that new, but in terms of volume, it is zirconia. What is zirconia? Let's talk about this, and then after we talk about the differences, what should a patient be asking for? How do they find a dentist that wants to, or can, and has skill set in placing zirconia implants?
For sure. Yeah, and I don't want to forget, the skill set is important because it's different. I used to place titanium a lot. That's how I was trained.
Right.
It's a different. You have to think in ceramic. Is kind of what I've been trained in. You have to think differently when doing ceramic, for sure. But
so let's talk about the pros of zirconia. One of my favorites, and it's more dentally related, is that how they look on an X-ray. Why is that important?
Yeah. I mean, it's always good to know what it looks like on an X-ray, because we have to make sure we know what the heck it is. I mean, that's first and foremost. But when it's more opaque on an X-ray, then you can you're able to see the borders. You're able to see. It shows itself, reveals itself a little bit cleaner and easier at follow-up appointments. I think one thing that we need to make sure too is that one of the misconceptions I see a lot is that people say, well, zirconia, that's still a metal. Zirconium is a metal. Mm-hmm. It has metallic properties, but zirconia is not a metal. It's a ceramic. When you put zirconium through a certain set of processes, it now becomes a ceramic. Just like sodium and chloride on their own are very different than when they are together in table salt.
So if it's not a metal, are there any oxides that are present or come out over time?
Yeah, for sure. So in titanium, what we're seeing is a corrosion problem. Mm-hmm. And that comes in three ways. A tribal corrosion is what some reports will say, where it's chemical, it's galvanic, and it's mechanical. Right. So we have, going back to kind of the chemical side of it, or what happens is you get these titanium ions, sometimes just during placement, sometimes it's peri-implantitis. Could be a lot of different things that will leach into the surrounding bone and tissues. Mm-hmm. And then your immune system takes it up and says, hey, that's not what we want, presents it to the immune system, and pretty soon we have an immune cascade that will chronically, kind of at a low grade, almost attack the implant and destroy the bone around it.
Is zirconia better in that area, 100%, or is it?
Ceramic, it has its own set of issues as well. I mean, you can still get peri-implantitis around a ceramic implant, yes, for sure. But what we know is that with that tribal corrosion, those leach of ions into the tissues is causing a major issue for people. And And I think it's on the rise, but metal allergies are an important component. Mhm.
So zirconia it's natural, it's sustainable. Talk about the aesthetics of zirconia with an anterior implant. That has always been a big obstacle, or not an obstacle, but a big item that has to be dealt with by the dentist. It's very difficult to do a good aesthetic implant.
The the best part of zirconia, in my mind, outside of it, that it's more biocompatible, and we don't have these metal ion leachings because there's no metal, it's all a solid block of ceramic, is the tissue. The soft tissues, the gum tissue, actually forms an attachment to the top of the implant, just like how it attaches to a tooth. And so a lot of your listeners might know what leaky gut is, where we get these this breakdown in the lining of our intestinal tract that allows things to get through into our systems that it shouldn't necessarily be there. I kind of liken almost periodontitis is almost like leaky gum, where we have this breakdown in the tissue or our protective defenses, where then bacteria get down into the bone and can create a systemic response. We don't get a soft tissue attachment around titanium. So then there's a nice little Trojan horse type of analogy of bacteria and virus and things can get down inside onto the bone, and then also cause some issues. In zirconia, we get the gum tissue actually attaches to the implant, which gives it a nice seal. And then, like you said, for in aesthetics, it's white, and so even if a little bit of it shows, it blends nicely with the tissue. And a lot of people don't even know when some of the top of the implant might show because it's white. They don't even notice it.
I think a lot of viewers or patients, they see the implant as a perfect restoration, a true artificial tooth, and it in itself has issues. So a natural tooth, when it sits in the bone and the tissue comes up against it, the little folds of the free margin of the tissue, the gum tissue, that has a little pocket there, but that pocket has a bottom. There is a connection, like a girdle around the tooth of fibers, and that seals off that connection between what's in the mouth and what's inside the body. But with an implant, with a titanium implant especially, that connection, that we call it the biological width, there are many terms for it, but that connection's not there. There is no girdle that seals that off. There is a free path from inside the mouth into the body, and the body tends to do pretty well. But again, that is an advantage with zirconia because some of that, not all of it, but some of that connection is restored. And I think that's a big deal because that is a big con for a titanium implant or an implant in general. Here's something a little out there, but we've talked about it. Tell people why it's even worse of an issue if you have an implant on that side, which is less than an inch away. You're holding the phone up there. You've got a metal that's within millimeters of the signal that's being generated by the phone. Why is that an issue? Why should people be concerned about that?
Yeah, for sure.
Yeah.
So a metal acts in your mouth like it acts anywhere else. And so when you hold a cell phone and Wi-Fi, EMFs are a big thing now. We know that they're causing some harm. And as we go from 4G to 5G, it's not like one step up. It's an exponential, it's a big jump. And so
in terms of energy frequency.
And as we get into these higher 5G, 6G, who knows how fast we need to have all this stuff working. When you put that cell phone up next to a mouth with some metal implants, it's an antenna.
Is zirconia less of an issue then in that regard, in terms of acting like an antenna?
Yep. So it's no longer any metallic property. So it doesn't corrode. It doesn't have a charge, a surface charge or anything like that. It tends to harbor less bacteria because it has no surface energy and being in there.
What are the cons of zirconia implants?
The idea that zirconia breaks is it's got a bad taste on the mouth from an implant called the Tubigen implant from the 1970s and 80s. 1980s, I believe is when it was. It was a really funky design, and they fractured like crazy. And that was, and it was a 1980s ceramic. So we have polycrystalline ceramics now. We have ceramics that are much more stronger and fracture resistant than we had before. But again, nothing's ever perfect. You can still get peri-implantitis. There is maintenance around an implant, zirconia or titanium, like there is around a natural tooth. And so taking care of it is important. You can still get peri-implantitis around a zirconia implant. Your odds of it are less, but you can still definitely have it for sure.
Right.
And I know people do say that they fracture some. I haven't personally had that. But I think that also comes down to like your occlusion, your bite. How are you making sure that that's appropriate
Right.
on an implant? Because in titanium, you can get a fractured screw, which is a big problem to have,
Right.
and that as well. So it's definitely something to be cautious of.
Just concluding things here. So the viewer now has all these options. I'm sure they've learned more about implants than in the past, maybe even from their dentist. So what should they be looking for? Let's say their dentist doesn't do zirconia implants or implants at all. What advice would you give them? How would you find a dentist?
Yeah, I think a good place to start is on your directory. Obviously, is a good place to start, and then also directories on the IAOMT, International Academy of Oral Medicine and Toxicology. I know a lot of my colleagues in there are very versed in ceramic implantology. And then there's another organization called the IAOCI, that is also a ceramic implant organization. And there's a directory there, I believe, that has a lot of dentists that place them as well. And I think just talking to your dentist about it, most dentists they want to listen to their patients. And if a patient comes in and asks them questions about, hey, what is this ceramic implant thing? If it was me personally, I'm looking into it. I'm saying, I don't know, but I'll find an answer for you, because that's just kind of what I do. Right. And I like to find answers. Right. So I think asking your dentist about it might be a good place to start as well. But I think there will be a push. Again, I'm not saying that they're going to take over the market, but there's a reason that the biggest implant companies in the world, Straumann, Nobel, they're kind of like the Nike and things like that of the implant world. They're all rolling out ceramic implants because I think they see the writing on the wall a little bit that
exactly.
We're having some issues with the titanium, and that, we also have, new pioneer or co-ops and food places popping up, health food stores, that there's a population push for health, I think. And we're being forced to respond by giving them something that we might think will be better.
How many titanium implants do you have right now in your office in a box? I'm just curious.
For sure. I'm exclusively zirconia now. I don't really place any titanium anymore. I have placed, I think, one this year, and it was a really different circumstance where size. Basically, the patient, they said, I want to have an implant. I don't care what material it is.
So that's my point. I mean, if someone's asking, I always tell people or patients when they're with their dentist, if they're talking about a procedure, I would always ask them, if you want an honest answer and you can't get into all the nerdy stuff and the technical stuff, just ask the dentist, is this something you would do on your mom or your daughter or son?
And even too, any dentists out there that are listening that are interested, I think if you place a couple and you see the results, like the soft tissue around these things is incredible, I think you'll really like it. I don't think it's something that we should fear because it's different. Again, it goes back to being open-minded a little bit. And I was kind of one of those guys where I'd place a lot of titanium and I'm like, gosh, I don't want to switch.
Right.
But then I thought, maybe I do want to switch. If this is something that's better and it can serve people.
Well, Cody, I want to thank you because we didn't get into all the detail of implants, but I think this has been very helpful for a lot of people because they really don't know what to ask for and what to look for. And I think a big part of it is they should be asking or at least considering zirconia. And I think one of the reasons you're so high on them in terms of regard is because you understand the complications of putting metal in someone's mouth. And again, that's because you're a functionally minded dentist. And again, I would just say to the viewer, don't be thrown off by his youthful looks. I mean, this Cody, Dr. Kriegel, he's really, for me, I mean, and I've been around for a while, represents the future of dentistry. And that is someone that will not put a metal into your mouth, which dentists have been doing for years. Look at the metal filling and silver and mercury, and that's got to come to an end. So I thank you for all the information and the discussion. We're going to get you back on the show. There's lots to talk about, testing and other biomimetic materials. That's a material that mimics life in the body, and so I'm excited for those conversations. But where would they find you? Are you on social media at all? I know they can find you on my functional provider list, but any information you'd want to provide, I'll put it in the show notes. Any links or
yeah, totally. Yeah. Our website, easy one for people is I live in an area called the Corridor. It's between two bigger cities in Iowa. It's corridordentalnl.com is our website, but you can find me on on Instagram. I post a lot about my family and things like that on there. And I think that's important for people to trust that somebody. They need to know kind of who they are and what they're about. And so Cody Kriegel DDS is my Instagram handle, and I'm pretty active on there as well. And so
Good. And how about teledentistry? Do you do any of that? Any consulting or?
for sure. Yeah, it is. On our website, there's a virtual consultation platform that we've developed. Actually did it at the beginning of COVID, so the timing was actually really nice in this telecommunication world that we're in. But I usually will set up a couple minute phone calls or Zoom conferences with people to go over anything and just see if they're a good fit for our practice and what that looks like, and just to be able to give information.
That's very helpful. I think that's a great way to go. So again, Cody, thank you very much. We'll see you again. And it's just great to get all that information, a lot of information that I think is very useful for a lot of our readers and our viewers. So again, thanks for your time.